Yes, certainly. My name's Dr. Jeremy Stone. I'm a consultant anaesthetist at Northampton General Hospital. I cover a lot of different lists. Predominantly, though, I do colorectal lists, not only the anaesthetic, but also the pre-assessment, including cardiopulmonary exercise testing. I also cover labour ward. I've been the clinical lead for anaesthesia on labour ward for 3 years, and I've also fulfilled the role for the clinical lead for equipment for our anaesthetic department too. In colorectal surgery, we have a range of different colorectal surgeons, a number of them, and we undertake colorectal procedures most days of the week, and we do significant colonic resections, maybe about 500 a year, something like that, of which I tend to work there on a Tuesday most commonly. We also have a labour ward which is quite busy for our district general hospital here in Northampton. We have about 4,000 deliveries a year and approximately a 25%-ish caesarean section rate. For patients having significant colonic resections, there are two main things that are important to consider, I think, which could prove to be challenges to the anaesthetist on the day. Firstly, you've got the whole package, including the surgery, including pneumoperitoneum, positioning, maybe steep head down, and the anaesthetic, and all the implications they have for people's cardiovascular stability. In addition, you've got the situation of patients who present for major colonic surgery may often have significant comorbidities, including hypertension, ischemic heart disease, and a range of other problems which may pose challenges to their physiology during the procedure. I think the main challenges for this patient group undergoing colonic resections tend to be the onset of hypotension intraoperatively, and sometimes that could be due to a range of different reasons which don't always manifest the specific cause straight away. They're quite busy operations, particularly at the beginning, where you have positioning going on, you've got a lot of setup carrying on, whilst you've got a full anaesthetic, trying to establish monitoring. You've got the surgeon positioning the legs, wrapping arms, so you've got quite a complex evolving situation. And then intraoperatively, the onset of a significant pneumoperitoneum coupled with head down positioning means that there's quite a stress can develop upon the cardiovascular system. Within this area, I'm quite interested in the patient's response to the types of stimuli that are occurring during surgery. And commonly, the onset of surgery, we see a sympathetic response. So you have a surge in blood pressure, which may be short-lived. You've got the effect of anaesthesia, commonly people using Tiva, so quite a lot of remifentanil and propofol, which got quite a profound depressant effect upon the cardiovascular system. And then the ongoing situation of things like the pneumoperitoneum can also activate the sympathetic nervous system, maybe diminish fluid and venous return to the right-hand side of the heart. So quite a complex dynamic situation can occur. So the things which I want to look out for are things like, well, does hypotension develop during this case, working out why that might be the cause, and working out what we can do to try to treat and maybe prevent it. Intraoperative hypotension during a colonic resection tends to be a mean arterial pressure below maybe 65 millimetres of mercury. We know that this tends to be associated with the onset of problems, complications and difficulties that patient may face post-operatively. I think if that develops during the procedure, we need to be aware of this and looking out for why it's happened and treating it. Here at Northampton Hospital, we, with the help of Edwards, did a piece of information and research to look at, well, how profound is hypotension within our practice, particularly during colonic resections? I think if you ask most anaesthetists, they would say, yeah, hypotension may be happening during some of my anaesthetics. I don't think it's my fault. Well, I don't think it's a big deal. But what we were able to do was to look at the information we took from some of our EV1000 and hemisphere monitors to say, well, do you know what? Let's look at the severity, the duration, and the profoundness of how severe this hypotension is. And actually, it's a lot more common than we thought. Intraoperative hypotension has implications at the time and maybe also further down the line in the future for the patient's stay. The concerns we have tend to be that hypotension could be associated with a diminution in the oxygen delivery to certain critical tissues. So that might be to the gut, so patients can develop an ileus and post-operative nausea and vomiting. In a colonic resection, hypotension can be associated with a lack of oxygen delivery to where an anastomosis is being created. Under those circumstances, the concern may be that anastomosis may break down and cause release of significant toxic substances into the abdominal cavity, which can be quite catastrophic for patients. That's often where a big area of concern may be, but there are other areas to think about too. So if you have significant ongoing hypotension, it can result in other organ dysfunction, such as the kidneys, so you can get post-operative renal dysfunction. You can also develop post-operative myocardial injuries as well. And these things have a significant burden for patient care post-operatively, maybe increasing their length of stay, increasing the amount of care which is required, which naturally costs money, and will often lengthen their length of stay. In intraoperative hypotension during colonic surgery, there's a resection going on. The sort of traditional way of thinking tends to be, well, maybe these patients are a bit dehydrated, so let's just give them some fluid if they're hypotensive. Or in our particular hospital, we quite like to use maybe metaraminol to cause vasoconstriction to raise the blood pressure. And that could be a very noble thing to try to achieve, to restore blood pressure back to normal. However, if the specific cause for the hypotension isn't clear, it might be we're instituting the wrong type of treatment. In Northampton Hospital, we were users of the EV1000 platform, so we had a familiarity and understanding of the idea of invasive and non-invasive monitoring of blood pressure, and including some of the parameters you can derive from that. So Edwards let us know about the Acumen Cuff, and we started looking into it in about the year 2021 or so. Like COVID has a bit of an impact with how you can remember that period of time. It was around about then. And then when we instituted this, we were trying to think about what would the potential benefits of this be? And then thinking about hypotension, if we were to ask an individual anaesthetist, well, do you get much hypotension during your cases, during colonic resections? They'd probably say, well, not with my anaesthetics. No, I think my anaesthetics are fine, thank you. But when looking more widely at the whole department, for all the cases that we're doing, with Edwards' help, we were able to measure the amount of hypotension, thinking about the frequency, the depth, the severity of this. So actually, we're able to look at this and sort of generate a number as to how much of an impact this was having upon our patients. And then implementing the Acumen Cuff, we were able to repeat that exercise. And that allowed us again to measure the frequency, the depth, the severity of the hypotension. And actually, we found that the Acumen Cuff, coupled with things like HPI and extra information, actually did reduce the amount of hypotension, the severity of hypotension, and the impact it was having. Additionally, what we ended up doing was to think about, well, maybe just having the cuff is fine, but perhaps with this Acumen Cuff, what we should do is have a protocol. So everyone's doing the same thing, everyone's behaving in the same way, and things are consistent. And what we found again was implementing this protocol, again measuring the hypotension, the number of events, how severe it is. Again, we found another improvement in the amount of hypotension we were finding during our colorectal resections. I tend to apply the Acumen Cuff at the very beginning of the anaesthetic. The patient might come into the anaesthetic room, or more commonly perhaps into theatre to go off to sleep. And what we tend to do is do the WHO check, establish IV access, and at that moment we apply the Acumen Cuff with all the necessary equipment to get the monitoring established. And what that allows us to do is to take some baseline readings, because our patients will come to theatre having been starved, so they may be a little bit dehydrated. We know that some of them will have certain diseases like hypertension, ischemic heart disease, maybe some heart failure. And what it allows us to do is to take some baseline readings of where the patient's at the moment, and maybe to think about whether or not there are any pre-existing elements of instability that we perhaps should be aware of. The Acumen Cuff in colorectal surgery is a very valuable tool. Having something like an arterial line or a non-invasive blood pressure cuff is fine, absolutely true. The addition of the Acumen Cuff allows us to do things like have an idea into whether hypotension is going to be becoming a problem in the next few minutes, few moments, to allow us to maybe predict what we should do to try to prevent this from happening, as opposed to chasing your tail and finding that hypotension has developed and then trying to work out what you should do to try to treat it, having therefore already been behind the curve. I think the additional benefit might be that some patients you might think, well, they're quite well, they're quite stable, their blood pressure's okay. They're having something maybe more straightforward, like a right hemicolectomy. And they're perhaps intended to go to level 1 care within the hospital. The Acumen Cuff, however, might reveal that they have an element of greater cardiovascular instability, And under those circumstances, the correct decision could be to say, well, maybe level 1 care wouldn't be correct because of the amount of cardiovascular instability we've detected, and therefore you perhaps wish to upgrade their care to level 2 for some closer monitoring post-operatively. The Acumen Cuff has some advantages over an arterial line. I think we're all quite familiar with the idea where you put an arterial line in, or you're unsuccessful, it doesn't work. Despite all of your attempts, you just can't get one in on a certain day. There are some colleagues that could help you out at a pinch sometimes, but sometimes it's just not possible. An arterial line can be subject to interference with damping. There are certain sort of mechanical problems which can develop. Certainly in colorectal surgery, patients have their arms wrapped quite commonly by the sides. The surgeons stand in close attendance, and there can be interference with them leaning on it, which can interfere with the blood pressure measurements that you're getting and interfere with any accuracy of any measurements you want to derive from it. The Acumen Cuff, however, is free of these sorts of problems. Robotic surgery is a relatively new thing in our hospital. We've had a robot for maybe about a year. The sorts of patients presenting for colorectal surgery that happens to be robotic are very similar to patients having standard laparoscopic surgery. The robot in theatre certainly initially was a bit of a distraction perhaps for everybody. There was a lot more work, a bit more understanding that people had to develop in order to work out how they should adopt and change their practice for what they're doing, to counteract the fact that the surgeon's sitting in the corner now and the robot's there undertaking quite a lot of the process. I think the Acumen Cuff allows us to have a presence in theatre to say, well, this is an important monitor, we need to have this. The robot's lovely and is absolutely helpful, but it's complemented by the Acumen Cuff to allow us to have constant and accurate blood pressure monitoring throughout the case. Using the Acumen Cuff pre-procedure allows us to get it established, functioning, working, comfortable for the patient, putting on whilst they're awake, to ensure that it's not pinching any skin or too tight and it fits well. Once that's in place, we can then give them an anaesthetic. We have an idea of the baseline monitoring we've got, some baseline readings to understand what the situation's like at the minute. And then most anaesthetists would say, well, I can give an anaesthetic without dropping the blood pressure when the patient goes off to sleep. And that may well absolutely be the case. But perhaps having the Acumen Cuff on before somebody goes off to sleep might just alert us to the fact that maybe some patients are more sensitive to the anaesthetic and allow us to detect any hypotension that could be associated with that process. During the procedure, if we're using the Acumen Cuff, it allows us to see the situation as it develops before us. So with HPI, it allows us to predict if hypotension is developing, so that intraoperatively that could be developing for all manner of reasons. There could be some decompensation in the patient's organ system. There could be some bleeding, which we're not necessarily alerted to. Whatever that cause may be, the Acumen Cuff can let us know that trouble's ahead maybe, and therefore what we should do about it to try to prevent hypotension. Post-surgery, if we have been using the Acumen Cuff intraoperatively, I would like to think that there's a greater element of cardiovascular stability intraoperatively, so that once surgery is all finished and the patient's in recovery or going to the ward, they've had a situation where their body's had consistent oxygen delivery to the heart, to the kidneys, to other organ systems. So those systems haven't got to undertake a period of recovery post-operatively. They continue to work as normal, so there's no struggling or problems or maybe further episodes of hypotension on the ward. We do know that patients who develop hypotension during theatre time are more at risk of hypotension post-operatively, and if we can reduce that in theatre, it's going to be much easier and safer for patients post-operatively. Using the Acumen Cuff intraoperatively for colonic resections, we often get an indication as the HPI number starts to drift upwards that something's not quite right. And sticking with that on its own is okay, but having extra information to let us know why hypotension is developing is really helpful. It's relatively unhelpful actually if you have hypotension because of fluid loss and you treat it with a vasoconstrictor. I think we'd all recognise that's an incorrect thing to be doing. So with the Acumen Cuff, what it allows us to do is to sort of peek a little bit deeper into why hypotension is imminent or has developed. We can look at things like the SVV, which will alert us to the fact that, yeah, maybe there is insufficient volume in the cardiovascular system, so giving a bolus of crystalloid is the right thing to do. It might let us look at the parameter of DPDT, so looking at myocardial contractility. And if we can recognise that that is under some strain and is struggling, we could institute measures to try to bring this back to baseline, hence the benefit of measuring it before you go off to sleep. That might take the form of maybe using drugs which are a positive inotrope. It might be, if you're doing TIVA, to reduce the drugs which are a negative inotrope, such as remifentanil. Other parameters which could be helpful are things like EA-dyne, so looking at whether someone's likely to be fluid responsive in the event that fluid is the correct choice for them. Using the Acumen Cuff in my practice has probably had a two sort of stepwise change. Initially, what it did for me was to make me not anxious, but certainly more aware of what was going on for my patients during surgery. My attention was partially increased upon the monitor to work out, well, under this set of circumstances, what's happening now? So to begin with, I was more aware of what was happening, and as I became familiar and comfortable with the information being presented over time, I was then able to sort of relax into the information to use it in a swifter, more appropriate way to say, well, do you know what? Now I can recognise that hypertension's coming because HPI is increasing. I can follow a protocol, look at the reason why this is developing, and institute action earlier. And that's become an easier process the longer we've gone on using it. Some of the key parameters with Hemisphere. Initially, we tend to look at HPI, and then that lets us think about whether there's trouble ahead, and therefore looking at the secondary screen and other parameters to say, well, that'll let us glimpse into what the potential causes could be. So if we had the situation where your SVV is rising, you say, well, maybe this is a set of circumstances whereby a patient requires more fluid. And in doing so, what we can see on the monitor is a bolus of fluid gets given by the anaesthetist. And then, whilst the SVV may come down and you think, well, all is well, the question might be, well, what impact has that had on the patient that I can see, that I can measure, that I can demonstrate? And actually, other elements of the screen with the information provided could be that you say, well, I can see the cardiac output now is restored back up towards what it was at baseline. The patient's stroke volume has increased by 5 or 10%. So there's an element of reassurance that what you've done absolutely is making a tangible difference. I think predictive technology, certainly in colonic surgery, for things like an anterior resection, can be very helpful indeed. This is mostly because a lot of our patients tend to be more elderly with their comorbidities, and knowing how their cardiovascular system and their other body systems are going to respond under the stress of surgery with the challenge of the anaesthesia is sometimes difficult to predict. We can risk assess these patients, we can let them go through cardiopulmonary exercise testing, but when it comes to the day of surgery itself, it can be hard to know exactly how things are going to go. So predictive technology can let us be alerted to the fact that trouble's coming, something around the corner isn't quite right. We haven't seen the manifestations of this yet on a standard blood pressure monitor, but the Acumen Cuff can give us a glimpse around the corner to say, well, something's happening, now is the time to act. The key benefits for using the Acumen Cuff in colorectal procedures, I think, is to enhance the accuracy and knowing of what we're doing, why we're doing it, and the impact it has. So it might well be that you can say, hypertension developing, it's going to be a problem, we should do something about it. But then using the Acumen Cuff, it allows you to say, well, actually, looking at the cardiac output, I am now able to restore it back to what it was like pre-surgery, before the patient had the anaesthetic. Taking those baseline measurements are so helpful and so important to know, well, what should I be aiming for? What's my target? If you put it on intraoperatively, it's a less certain sort of situation. So some of the key benefits are knowing what you're aiming for and knowing how to get there. I think patients quite enjoy being involved with their care. So at the beginning of something like a colonic resection, before the anaesthetic happens, we will put a drip into their hand, a saturation probe onto their finger, and then put the Acumen Cuff onto their other arm, along with the measuring cuff. And they're involved in their care. They quite like it. They look at it and go, oh, what's this? They don't see this sort of equipment on the general wards, whereas a blood pressure cuff, a drip, and a saturation probe they're really familiar with. So actually there's an element of intrigue perhaps. They quite enjoy it. They say, what's this for? And we can explain it to them. So they feel involved with their care. Some of the challenges using the Acumen Cuff in our department may be that some of my colleagues are maybe a little mistrustful of new technology, don't necessarily see the need for it, or don't understand the need for it. So that education and understanding is clearly one way to break down some of those barriers. In our hospital, certainly one potential barrier might be having access to a number of machines. We were required to purchase them. So it's not possible to have one in every single theatre. So it's our role, our job to ensure that we provide enough monitoring equipment for the patients to have for the correct procedure. Engaging with my colleagues is vital, really, to getting them established into using it. Some people are very keen, some people are slightly keen, some people are unkeen. I think one key way to get people engaged is to show them quite how easy it can be to attach and put on and use the information as well as the equipment. With the help of some of the clinical specialists, training the ODPs and anaesthetists, it's quite easy to show them how straightforward it can be to set up, attach and gain some information. And then a little bit of support to say, well, how do we use this information to our best advantage is often the way to show people what it can do and what the benefits are. Using the Acumen Cuff has sort of changed my practice a little bit. One of the things I've noticed seems to be that I'm able to identify patients who are more cardiovascularly unstable during the operation than I perhaps would have expected. So on an individual level, you can say this patient should have a higher level of care post-operatively, or I need to do things different intraoperatively than I would expect for that individual patient. As word of mouth through the department sort of spread, more and more people were saying, well, today I have a patient who's having an anterior resection, they've got some heart failure, the kidneys aren't very good, I'm a bit worried. What can I do to enhance their operation, to optimise their anaesthetics, to reduce the risk of comorbidities causing problems for them? And they'll sort of look to whoever the equipment lead is. When I had that role, they'll say, well, how does this work? How can I use this? So word of mouth spreads, a little bit of peer support as well as clinical specialist support. And then over time they say, well, that worked, that was helpful, really good, thank you. I'll use it next time, and then next time, and then next time. And slowly, as familiarity sort of grows, people then say, well, I've used it for my anterior resections, for colonic resections, maybe I could use it for other things like head and neck cancers. So it gradually spreads out over time. Implementing teaching is always a challenge when it comes to a new piece of technology or a new idea of thought. So what we tried to do was to develop a small group of super users, people who had greater depth of understanding of how the technology fitted, how it worked, what it meant, and how we could implement it. And then we had a small group of people using it for the first time, second, third time in the theatre, becoming more familiar. And then we would then look at identify theatres in which we said, well, today there's an operation over here, we think this patient may benefit from it. So one of the super users might say, well, I'll come to your theatre, I'll give you some assistance. Oh, thanks very much. It's very nice to have a colleague in theatre to help you out. And in doing so, knowledge was spread, word of mouth comes, and over time, more and more people become familiar with using the Acumen Cuff and interpreting the information. Yes, there was some really helpful workshops and courses that I attended virtually during the COVID period. I remember my daughter was at home, not able to go to school, but online at home we had a really impressive live demonstration of the cardiovascular physiological impact of blood loss. And the idea being that, well, certain parameters you would expect to change didn't change. So you thought that maybe heart rate would rise initially as a compensation mechanism. You want to think, well, actually, that didn't happen in the way in which we expected it. And then looking at the model that was being shown, looking at how HPI changed, the different parameters of cardiac output and stroke volume, and looking at that type of information gave us a clearer picture to what was actually happening. So that sort of training sort of revealed the ability to look at the information and use it to make decisions without the need for sort of actually giving an anaesthetic at the same time. So more of your brain was freed up to focus solely on that. So it's really helpful. We do have a protocol that we can use with the Acumen Cuff, particularly when using for things like colonic resections. It's a relatively easy to follow protocol, I think, and we have it laminated and attached to the machine so it can't go missing and go wandering. And the idea being it starts off with a basic premise of, well, is the HPI number changing? Is it trending upwards? And if so, what should you do? It's quite an easy to follow, not too complicated diagram that allows you to come to different conclusions. And I think that all of my colleagues who've used it say, yes, I understand it, it's easy to follow, not a problem at all. Some of the outcomes we've noticed with the Acumen Cuff, we haven't measured specific patient-related outcomes, but what we have noticed with Edward's help, we have measured the amount of hypertension we've had intraoperatively, and that certainly has diminished, certainly with the implement of the Acumen Cuff, and then the addition of a protocol, we do know that we have reduced the frequency and severity of hypotension. What the medical literature tells us is that hypertension is bad for people. So what I think we should be able to demonstrate in the future might be that with less amount of hypotension, we have maybe a shorter length of stay perhaps for people having this type of surgery, and maybe things like fewer amounts of comorbidities and adverse events post-operatively. We haven't measured that, but it's something I'd be keen to do. There's probably quite a wide range of patients who could benefit from the Acumen Cuff. Whilst we use it certainly in colorectal surgery and sometimes on labour ward as well, we do have other patients undergoing major head and neck cancer work in our hospital. Commonly they'll go to intensive care afterwards, so do need to have an arterial line, but it doesn't mean that the Acumen Cuff has no place for them. We also, with our robots, we do robotic prostatectomies, which take a couple of hours, so patients may benefit from the idea of having the Acumen Cuff as opposed to frequent inflation and deflation of the standard blood pressure cuff on their arm, so there could be potential benefits for them too. What we've noticed with Acumen Cuff and non-invasive monitoring, some of the advantages at the beginning of the day tend to be very simple setup and short time to set up. So rather than relying upon an arterial line, which may not take very long, sometimes it does take a bit of time. But certainly there's an element of certainty with the Acumen Cuff that you can put it on and have the machine and monitor ready to go in a very short space of time, and there's no delay or uncertainty about that. And then following on from that, using this technology, again there's quite a lot of certainty about consistent monitoring in theatre, and if that reduces our hypotension, which we know it does, the wider benefits could be the fact that there's fewer complications post-operatively, so patients have a shorter length of stay and have better outcomes. I don't know precisely what's going to happen, but I think the future with the Acumen Cuff in our hospital is certainly going to be a wider adoption of its use under a range of different circumstances. So for the time being, we use it in colonic surgery for anterior resections and the like. We use it on labour ward as well. But other groups of patients who are not very well, at high risk of complications, are often people undergoing trauma surgery, so patients with broken hips, fractured neck of femurs. They tend to be elderly, tend to have a huge range of comorbidities and at very high risk of things going wrong. So the Acumen Cuff, I think, here has a great role for us to play, is for us to find patients who've got instability. Patients whom we think, well, hypertension here is likely to be very problematic. So can we see it? Can we treat it? Can we prevent it?